Hello, everyone, and good evening. Thank you for joining us today with my IVF answers. Tonight, we are talking about from mature oocytes to embryos. How many embryos can you expect? And this is in regards to understanding embryo attrition rates, or what we sometimes also call the IVF funnel. I am your host tonight. I am Sandy Christiansen. I'm a clinical embryologist. I've worked in the fertility space for over 15 years now. I'm also currently supporting patients who are navigating fertility issues and treatments as a patient support advocate and educator. Tonight, we've got two wonderful experts with us. We've got David O'Rourke from Freya Fertility in Denmark. David, would you like to introduce yourself?
I am currently the Director of Embryology at Freya Fertility in Denmark, a fantastic little clinic. I've been an embryologist for 15 years as well, so similar to you, Sandy. I've worked in many countries across Europe, and most recently working in London. So really excited about this evening's talk because I think it's a conversation that we have with most of our patients. So I think it's so interesting, it's so important. So looking forward to questions.
Brilliant, thank you. And Renata, you are joining us from IVF CUBE in Czech Republic. Would you mind introducing yourself as well?
So I've been working in IVF field over 30 years. And I'm recently running the laboratory in Prague. So I'm a president of the Embryology Association of the Czech Republic as well, and doing some audits for IVF centers as well, if they want to get the certification, for example, for the good practice or whatever. So working all my life in embryology, like embryology, and so hopefully I will answer the question of our patients, what they need.
Amazing. Thank you both so much. And yes, just for everyone's awareness, this session is being recorded. You are welcome to use the Q&A box to ask any questions this evening. Your name will not be in the recording, so it is anonymous questions. So feel free to drop everything in that as we go. Try to get through all of your questions as much as possible tonight. And also, if you do need to dash, like I said, this is being recorded, and the recording with the link should be sent out tomorrow. And you can always access previous recordings as well on the My IVF Answer website. So because we don't have any questions in yet, I thought maybe we could kick off the conversation around kind of typically what you see in your clinics, I guess, around average number of eggs that are collected. And we know that this is something that can vary a lot with age, but sometimes we have a bit of like a range for national averages. David, do you want to talk us a little bit about what things look like at your clinic in Denmark these days?
Yeah, absolutely. So I think, I suppose, as you said, that there's quite a significant range when we consider the amount of oocytes that are collected. Mostly that comes down to stimulation cycle that the doctor would put the patient on. And the doctor will base that based on some of the hormone testing that they would do to determine the prognosis, and it would kind of determine the amount of medication that a patient would need. What we aim for is somewhere between 10 to 15 mature oocytes. Now, that's a total average. So I think the caveat to that is that there's many patients who get less than that, and there's many patients who get more than that. And I think the real key word there is 15 mature oocytes, which is obviously the most important thing when we're doing that oocyte collection. But there is definitely a window of a number that we would expect to aim for.
Yeah, and that's a really good point. I think the HFEA, which is a regulatory body in the UK, have also said that like 10 to 15 is kind of a generic average that we see across all ages. very much dependent on age and multiple different factors. So we know that those, for example, who have PCOS, have multiple follicles, they are sometimes at risk of hyperstimulation, which means they could produce potentially a lot more than those 15. And there are those who maybe have low ovarian reserve who might have a lower yield. But again, lots of factors that influence this. Renata, do you think, does that align with what you're seeing in your clinic, or would you say you've got a different?
Yeah, that's definitely that's the same thing. So the target of the stimulation is something between 10 to 12, 15x. So that because it's safe for the patients as well. So that's what we have to look for. So to be safe, and the treatment must be optimized for the patient, for the age, or all these factors what you already mentioned. Yeah.
Yeah, definitely. And David, you also mentioned something quite important here around, mature oocytes. So we know that during the ovarian stimulation, one of the kind of key components we're looking to achieve is like a synchronous growth. So you want all of the follicles that are in that like immature state to be able to grow at the same rate at the same time to hopefully get that same amount of mature oocytes. However, that's not always the case. We tend to have certain KPIs that we like to hold ourselves against too. So, in some clinics, that might be about 80 to 90% of the follicles that we're collecting from, we hope to have mature oocytes in them. And that is something that I think that's the beginning of our funnel, really, where we start from the follicles to the oocytes collected. We do have a couple of questions that have already come in, so let's go ahead and start with one here. So first question, and David, I'm going to go ahead and ask you, is there an average, so I guess average number of oocytes for patients under 35 whose factor or only factor is missing fallopian tubes? That's an interesting one.
Okay. So that's a really great question to, I think, start with, because so when we first kind of consider a patient, the biggest factor with the prognosis is the female age. And so under 35s, or 35 is our first kind of cutoff point where we start to differentiate the ages going from 35 up to over 40. So being 35 or below is in our best prognosis. If it's an anatomy problem as opposed to a hormone problem, that's a good sign. So it's, I think, without knowing the patient's kind of AMH and not knowing some of those hormone levels, let's guesstimate that that's normal. It would be that perfect patients that we talked about to aim for that 10 to 15. And I know we're going to talk more about the attrition rate, which would be what would we expect to see in terms of fertilization and how would we expect to see that embryo develop. But based on that patient, just knowing her age and that simple information, you would aim for that 10 to 15 because you think that that would give you sufficient number of blastocysts to hopefully have a transfer and have something to put into cryopreservation. So it kind of falls exactly within that window that we initially kind of talked about. So the doctor very much would be looking at how can we achieve 10 to 15 mature oocytes for that specific patient. Do you have a visitor there?
I do, sorry. Like a golden retriever basically on my lap now. No, I think that's again, like such valid points here. There are a lot of factors that can like influence fertility in general. Missing fallopian tubes is an anatomical issue, which means that unfortunately when trying to conceive through intercourse, that's something that won't be achievable. So it's not necessarily infertility in the sense of you've been trying for 1 year and it hasn't worked, or you have a hormone imbalance or irregular cycles or a condition like PCOS or endometriosis. So typically that would be in, to your point, that good prognosis category. So Renata, I've got a different question for you here. Somebody is saying that she is 40 in her last cycle had 7 mature oocytes, but only 2 fertilized and 1 reached blastocyst. So they're wondering, does this sound typical or could something be wrong?
So just summarize the question: 7 eggs retrieved, 7 matured, and 2 fertilized.
Correct, and 1 reached blastocyst.
But like standard IVF or ICSI already, that
I'm
could
sure.
be.
That could also be a factor, correct? Yeah.
Yeah, I'm sorry. So because we know, so there could be still some effect of the binding the sperm on the eggs, and so we may lose some eggs, even mature eggs, so then won't be fertilized. But anyway, so at the 40, so we always can have like different quality of the eggs, even they are the mature. That's not just about the mature status of the eggs. So we always may see another signs how the quality of the eggs is visible. So, and then we may say if the eggs are, let's say, good quality or bad quality, and that could depend on the fertilization. Even the fertilization up to me is quite easy process, let's say. So more important is development than after the fertilization. So again, so this is like to say the most proper answer on that question. So we will missing some information to be sure what was going on. So, but still, it looks very bad. So, but to get 1 blastocyst from 2 fertilized eggs at 40, so I would say that's a good reason.
Exactly. Yeah, I think on paper, 2 fertilized out of 7 mature oocytes does not align well with our typical KPIs. So that's something that would be suboptimal. So then a lot of things, I think, in a lot of cases, you would come back into the clinic for a follow-up consultation with the doctor to discuss those things. What possibly went wrong here? Is it a fertilization element? Was IVF done? Could ICSI be considered in the future? There could also be elements related to the stimulation process, but having 1 blastocyst out of 2 fertilized at age 40 is actually a really good yield. So that is encouraging. I think we got a second message here. She's saying that just worried about going through the whole another cycle again, but appreciate the concern and understand that's been difficult for you, and possibly really hard to take. And again, this is the topic tonight, this attrition rate. You start with 7 and only 2 fertilize. That's a big hit, and that's something that would be very unexpected and difficult to process. But definitely, if you haven't already, have that follow-up consultation and see what they can kind of like piece together from that previous cycle to see what can be improved in the next cycle. Any additional thoughts? Yeah, David, go for it. See you nodding along.
Quite an interesting case, and I know there's gaps in the information there, but I think 1 blastocyst from 2 fertilized oocytes is very positive. So that's above the average that we would see across the patient group, which would be roughly 40%. But the next factor that we got to consider with that blastocyst is aneuploidy. So looking at what the aneuploidy rate of that blastocyst would be. And I'm not sure if there was PGT testing done with this embryo. But that is something that would definitely have to be considered, and I think it would have to kind of go into the conversation if you're going to do another cycle. So I think it's good to have blastocyst. It's important, of course, but we also need to know the kind of aneuploid rate, and we also know after 35. So I talked a little bit about our highest prognosis patients is under 35. One of the main reasons is because of aneuploidy, and the chromosomes start to get, lack of a better term, sticky after that point in the eggs. And we know that greatly increases by the time of 40. And so at 40, we've got a couple of factors that we need to consider. So it's first of all getting a blastocyst, and then getting a euploid blastocyst in order to get the highest possible chance for a pregnancy and for an outcome for that lady, hopefully.
And maybe another thing as well. So each cycle is different. So if we would do the same stimulation, let's say just imagine this situation, so we will get a different answer. We will get different number of the eggs. We will get different quality of the egg. So that's always something new and something different. So we wouldn't even get, let's say, the same answer of the body and the same result. This is another thing what must be taken into consideration, what the patient should know.
Yeah, that's a really good point, because you learn a lot from a cycle, right? You learn a lot from any given cycle. So you would only think that you would get a better outcome doing a subsequent cycle based on what the embryologist learned from that first cycle.
Great point. Excellent. Thank you. We have another question here, and this is in regards to the blastocyst stage in general. Is that definitely better for success in embryo implantation? David, do you want to start? Are blastocysts better?
So I think over the last kind of decade, most clinics have very much moved towards to blastocyst culture, and I suppose there's a couple of factors for that. The longer we have embryos in the lab, the more data we're able to get from that embryo, and the more information we're able to get from it, the more we're able to determine the chance of a live birth. So initially, we always try and advocate for day 5 in order to give us the opportunity to make the best selection of an embryo. We still know that day 3 is common, and we know people get pregnant from day 3, but it's nearly guaranteed, but we can't absolutely put our finger on it. If we had left that embryo until day 5, we probably would have potentially selected or cryopreserved, because it would have continued to develop on to be a blastocyst. I think one of the important things happens after day 3. So if we're transferring an embryo on day 3, we don't have the full picture. So on day 4, the embryo goes through a process of compaction, and it starts to form a blastocyst. And in a blastocyst, we start to see the 2 cell types. So you can see the inner cell mass, and we see the trabectoderm cells. And so we know that it's got the cells in order to continue going into implantation, and has the cells, the inner cell mass, which go on to develop on to be the baby. So I'd like to answer the question. It's important, but it's not to say that pregnancies and perfectly normal pregnancies and live births occur from day 3. And it comes down to selection, I suppose. So if there's one embryo that's been fertilized, and there isn't the need to have all the information, we know we're going to transfer it, maybe it's best to transfer it and put it in the uterus, put it in the environment that it should be. But if we've got many fertilized oocytes, 10 for example, then we need time to select and make sure that we've got the opportunity to select the best possible embryo to give that couple the chance of a live birth. So there's a couple of factors that come in that kind of decision making, but that would all be kind of explained with the patient. That would be a conversation with the patient and the doctor, but hopefully that just kind of gives some kind of elements to the conversation that we would have, and some of the different scenarios that we would see.
Definitely. So it's not necessarily always better, but sometimes it's preferred, and that can be for a number of reasons. There could be clinic preferences. I mean, we've all worked in a couple of different clinics. I've worked in clinics who, for example, didn't want to perform certain procedures across the weekend. So transfers would be pushed dependent on staff availability. So if we couldn't have the right staff, then the transfer would be on either like a day 2 Friday or a day 5 Monday, just to avoid weekend work. And that those were things that were done, and typically they would still have good success rates. So it wasn't compromising the chances for the patient. It was trying to do the best all round. But equally, I've worked in laboratories that did nearly 100% blastocyst culture, and if you just had one, it would still go to blastocyst, and that was it. So there's a range of different reasons, and ultimately, main point is everybody wants it to be a successful implantation. So we try to do our best to get there without compromising your chances of success. Renata, how do you feel about it? Do you do 100% blastocyst culture, or how do you feel about that in terms of success
Yes,
rates?
we have. I used to transfer the embryos on day 3 as well. So in years ago. So, but anyway, so I'm totally agree with David. So nowadays there is like whole goal is the transfer blastocysts on day 5. There is always some pros and cons. So, but generally, the blastocyst should be in uterus. So that's the place where the embryo should be in that stage. If we have smaller embryo, like day 3 embryo, so they won't be in vivo condition, then won't be in a uterus. So that's another thing is this is something what would be like positive for day 5 blastocyst transfer. So, but another thing is there is many studies about the condition, laboratory condition, and some influence of the embryos as well. So there is another thing is maybe it's better to transfer embryos earlier than later. So always, so, and David mentioned that as well. So we always need to find a way or check the way would be the best for the patient. So of course, so there'll be some, let's say, general policy of the laboratory, how they treat the patients. So, but usually there is always some possibilities how to tailor the therapy for the patient. So, and that's the goal of the treatment, I would say.
Of course. And I think another aspect with this that sometimes ties in is also if you have surplus good quality embryos, a lot of clinics prefer these to be frozen on day 5 with vitrification, as this is the kind of a routine method of freezing these days. It's a flash freezing process that has really high success rate, like close to 100% as we can get in terms of the freezing and thawing, and that's what we like to have. And also, again, sometimes we do just have more data on blastocysts and their ability to generate a healthy pregnancy, so we can easier equate what you've got in storage as well to chances of, whether that's new pregnancies or sibling treatments. Sorry,
You
Renata.
mentioned, I'm sorry. So, but you mentioned, for example, that the cryopreservation, that's another big, like, subject of the IVF. So, but you mentioned that the vitrification is the best for the blastocyst. So that's true, of course. So, but I would just mention we can freeze any stages. So that's just depend if you know how to treat them. And it's again, so there would be the policy behind it, what you would vitrify, when you will thaw it, when you will transfer it, whatever. So, and since we know what each stages of the embryos would need, so we are able to keep them.
I think it's really about kind of treating couples as individuals. So we've got many strategies, we've got a lot of tools in our kind of tool belt in order to treat any kind of given couple or person. And we kind of draw upon these based on what we see. But that can also change day to day, because biology can also be, kind of a strange thing sometimes, and things kind of change time to time. And that's why we keep a close contact with our patients to inform them, to counsel them, and to really make sure that they're part of the decision making, because we're only custodians of those embryos for a short period. And it's obviously we get input from medical. But yeah, I think it's just about kind of being as bespoke as we can based on what we see and what we think is the best, based on history. So yeah.
And that actually, I think, ties in nicely with we have a follow-up question from the woman who asked previously. She had her 7 eggs, 2 fertilized and 1 blastocyst. So Lisa, thank you so much. I'm just trying to decide whether she should plan for more cycles. If my average blastocyst rate is likely low, how do patients and doctors usually estimate how many cycles you may need? David, do you want to kick off with that one?
Yeah, absolutely. So, I think this is a common question. And of course, going in, it's a great question to ask, because you have to kind of start with a number and kind of work backwards. And so you're starting with a pregnancy and working backwards. And so, again, bringing up maternal age being one of the biggest factors. And so there's been quite a lot of work that's gone into numbers needed in order to achieve pregnancy. And as we talked about as well with this specific case, aneuploid rates. So we need enough oocytes to fertilize successfully, to create embryos, to then be euploid. And I'll probably start just by talking about any sort of random cycle for a patient at 40. And so let's just guesstimate that 10 oocytes were collected. We expect to see somewhere in the range of 7 would normally fertilize. Of those 7, we'd expect about 40% of those to create blastocysts, and blastocysts that we can use. So they're of sufficient quality to transfer or to freeze. And so for 7, we're talking about 3. At 40, the chance of one of those blastocysts being euploid, so being genetically normal and balanced in terms of the chromosomes, we're probably talking at about somewhere between 10 to 20%. So that number goes from 70 when the patient's 30, right down to about 10 to 20% when they're 40 or below. And so if we think about that, we probably need somewhere in the region of at least 10 blastocysts to get 1 euploid. Now, that's just talking top numbers. Caveat to that is that you could get a euploid embryo in the first cycle. It could be the first one that you test. You could be lucky that way. But unfortunately, it could be the last one. And so it's difficult to determine for any specific patient how many cycles they should do, but just looking at big data sets, that's the kind of numbers that we kind of look at when we're looking at a patient at 40 without knowing any other information. That's kind of high level numbers.
Yeah, Renata, any follow-up thoughts on that?
Again, so I just can agree with David. So just maybe I'll be more skeptic how many euploid embryos we can get if the patient is over 40. So 20% looks really good. So I would say that's worth than 20%. That's up to maximally up to 10%. So it's really, and every year in getting older, the patients 40 is different than 41, 42 is different than 41, so it's every year it's getting the deeply down numbers of the euploid embryos, even numbers of the eggs. So it's really, really age dependent, and doesn't matter how we feel. I mean, how the patient, I mean woman, sorry. So how the woman feel, I can feel healthy, I can be I can run a marathon, whatever, so I can be very strong, very healthy, no stress, nothing like that. But unfortunately, it doesn't matter. So my age is still my age, and that's the problem.
Yeah, you're absolutely right. Like, and I think, going 40 and above time is really of the essence. So we see that aneuploidy rate roughly half every year. So like 41 will be down to 10%, of 42 will be down to 5%, 43, 2.5%. And so the longer it goes on, the more blastocysts you need, and you nearly need to double them. So, yeah, and then that turns into a lot of cycles. So it's it's something our time is really of the essence, right?
Yeah. Thank you both so much. I think it's Renata, to your point, it's something that's just so difficult, isn't it? Because with fertility, there are no clear signs of fertility problems. There's not enough education around how much an impact age has on fertility, really. And David, at the beginning of these conversations, you say like age is the female age is one of the most important factors. And so it's really difficult when you've like done the things that you wanted to do, right? Whether that's your career or, you got married, you did everything right, you're ready to start trying for your family or grow your family. And it's not working as quickly or the way that you'd hoped, and you realize there's this entire world of fertility, like just sometimes problems or treatments that nobody ever taught you. So it can be a really difficult thing to go through. And again, support from your clinic, number one. Try to get that follow-up consultation, have a discussion around particularly like see what can be tweaked there in that fertilization rate, because you started off with a good amount of oocytes. Like that was a really strong start. So it is possible that in that next cycle you could have more blastocysts if you had more fertilized eggs. But again, to David's point, whether that will end up with a great blastocyst that generates a pregnancy in the next cycle, we won't necessarily know if that blastocyst would do, if it's in the next cycle or another cycle down the line. Yeah. Okay, in terms of these attrition rates, then you talked a little bit to that already, David. If you have your 7 fertilized eggs, you hope around 40% make it into blastocysts. So these like your clinic's KPIs. I saw an email from Escher the other day about the whole alpha consensus on coming back out again. What like standards do you hold yourselves to in the clinic?
Yeah, so I think we benchmark ourselves on guidelines, but always aim to achieve higher. So we benchmark ourselves on a minimum fertilization rate of 70%, but our actual average fertilization rate is closer to 80-85%. And I think that comes down to a number of reasons. So of course, we do a lot of semen analysis before we would go into patients. We try to learn as much as we can about patients prior to coming in for treatment. Often, if we don't have a clear picture for fertilization, we'd often do split cases. And this is just to minimize the risk of not fertilizing successfully through IVF, especially if it's a first cycle and we don't know enough. And I think that those
by split, do you, just to clarify for everyone, like a 50-50 IVF, conventional IVF versus ICSI, yeah?
Exactly. Yes. Sorry. And that helps us kind of mitigate against some of the risks. And so we're trying to minimize the risks and maximize the output. And so that's one of the ways that we achieve a higher fertilization rate based on the benchmarks. Beyond that, we it's kind of, there's kind of two philosophies in terms of embryo development. We've vastly moved towards a single step, which is leave the embryos alone and let them develop and don't disturb. And we do that by using time-lapse incubators. And time-lapse incubators take pictures of embryos every 10 to 15 minutes, and we're able to use that as essentially a video of embryo development, looking at the embryos dividing and being able to keep a close eye on positive things that happen, but also negative, which also helps us with selection of embryos. But based on a single step culture system with time-lapse incubation, we generally see about a 40% blastocyst utilization. And utilization means that we can transfer or we can freeze. So they're of sufficient quality to transfer to freeze. Now, we achieve close to a 50% blastocyst rate, but that extra 10% are embryos that aren't of good quality to freeze, because we know very low quality embryos don't go through the vitrification process that you talked about for cryopreservation. They don't go through that very well. And also there could be blastocysts that don't have one of the very key cell types. So they might not have an inner cell mass. And so that means that they don't have the cells in order to keep on developing and achieve a live birth. So that's kind of the general numbers that we look at. When we start going further into implantation and live birth, then it's very much benched against age. And so our pregnancy rates are the highest for 35 and below. As we talked about, there are our highest prognosis patients. They have the lowest incidence of aneuploidy. So we achieve about a 50% live birth rate. And unfortunately, that starts to drop quite quickly as we go to 40. And as we talked about before, going beyond 40 as well, it starts to really kind of drop.
That's brilliant. Thank you. So yeah, it's just kind of helps understand a little bit just that funnel, and something that we discussed at the beginning. It's something that not every clinic is as good at like preparing patients for, especially if you go in, you start off with 10 eggs, you get a call the next day, and then maybe your heart drops because you find out that you only have 5 fertilized. Well, out of those 10, maybe only 7 or 8 sure, slightly below your averages, but like then the fertilization rate was good, acceptable. And then, after that, it is that funnel that can continue to decrease the number of embryos that are available. It is a natural part of the process, and I'm not saying it's something that we want. We don't want them all to drop off necessarily, but it does help the selection process as well, because by the time we get to that stage of transfer, we have hopefully then good quality embryos that have a good chance of generating a pregnancy. Renata, any other thoughts around the funnel? Do you have kind of similar percentages that you hold yourselves to in the clinic that you try to achieve?
I would maybe point it out a little bit general things. The first thing is that nothing is for 100% sure in a biology. So you always have to count that if you have, let's say, 10 eggs, you can be sure that, or won't be surely 100% matured, 100% fertilized, whatever. So this is what always needs to be pointed out for the patient as well, so that if we have 10 eggs, we wouldn't have 10 embryos. And that's sometimes what we need to explain to patients as well. So because they expecting 10 embryos from 10 eggs. Another thing is that good laboratory will always look at the KPIs, but be sure that the KPIs are numbers from some average population of the patient. But another thing is that every patient could be different, and it's really if I would say that we have, let's say, 85% fertilization rate, like general things, so I will still have the patients where we will get just 20% fertilization rate, and I will get the patient who would have 100% fertilization rate. So, and sometimes this would affect the patient's feeling if they go through the therapy as well. If I would say, well, 80% we will have the fertilization, for 40% blastocysts, whatever. So, but as I said, and David mentioned that, and we are talking about it through all our session already. So everything must be tailored to the patients. There is so many factors what could affect the outcome, and it's really hard to predict something, because you never know. It's everything is about the statistic, of course. So, but the patient want to see or get something more, but we can't get them more. So because we do the most things what we can, we try to at least predict a little bit what would be the best way, what should be the next step to get. The whole goal is to get the pregnancy at the end, well, the baby at the end. So, but it's always the let's say, guess. And even we may think this factor, think about that, think about the whole things together. We always just wanted to do the best work, but we would never be sure. And that's the problem. We can't promise anything.
No, that's a really good point. It is, they are predictions. As scientists, this is what we have. We have numbers. we have our statistics. We have these percentages that we rely on. But there are risks everywhere along the way. Thank you. Yeah.
And maybe that's why we are talking mostly about the numbers and percentage, because this the let's say the world like now today. So everything must be counted. Everything must be done for 100, 110% sure, whatever. So we are so focused on the numbers, and maybe that's actually stress us, and that's why we can't succeed at the end. So so we just wanted to get everything what we can, and we are just the focus on the, as I said, numbers and percentage, whatever. So, and that's, I think it's not actually a good idea. So I think the people should be, or the patient should be informed, of course. They should be the part of the therapy, but trust to people in IVF centers that they do everything for them what they can.
And I think it's quite easy to talk about numbers, right? So it's quite easy to kind of give these kind of high level numbers of what we would generally expect, but it doesn't really tell the human story, because those numbers are reflecting hundreds and hundreds of cycles. And every one of those cycles, as you said, is totally different. And we see totally different things from different patients, which kind of goes right back to our toolkit, where how can we be individualized for each one of those patients so we can give them the best possible outcome, the best possible prognosis. And so there's many, many human stories within those numbers that aren't represented in them. Because biology can be incredibly surprising, but I think it can also be incredibly cruel. And unfortunately, we see both sides of that, and the numbers don't really represent it when we kind of talk high level numbers.
That's a good point. Thank you both. Got a few more questions that have come in now. David, for you, ICSI is used in many clinics, even when sperm quality is normal. Do you think it's possible that unnecessary ICSI can actually increase attrition in some cases?
Yeah, it's a good question. And we see kind of different things in different countries and different policies in different clinics in the same country. And what we see sometimes is most of the places that I've worked have really maintained kind of 50-50 on IVF ICSIs, and not kind of the nearly easy thing or the minimization of risk is to go straight for ICSI. So yeah, it's a really good question, because yeah, I think if you did 100% ICSI for all of your patients, you have a little bit more data. So you're able to know on day 0 the maturity of your oocytes. And also from doing an ICSI procedure, you're able to kind of get a feel for the quality of the oocytes as well. And that's kind of, you get that from doing the injection procedure. And so the embryologist is able to kind of get a bit of a feeling of what the quality might be. And so you might get a little bit more information, but from doing ICSI, you lose a little bit of an element of natural selection and a little bit of individual sperm kind of fertilizing an oocyte. Does that increase the quality of a blastocyst? I don't know, to be honest. I don't think I have the answer really for that one, because there's such a spectrum of different things that are happening. There's no clear answer within the things that I see of one being better than the other. Yeah, so that's an interesting question. I don't know if you can shine a little bit more light on it, but yeah.
We've previously done a session on to ICSI or not to ICSI, and my 2 experts both worked in 100% ICSI clinics. So they did 0 conventional IVF, but they did a lot of validation before shifting to full ICSI, and that was not a risk that they saw. So I would not think that ICSI would increase the attrition rate. There are some oocytes I think we've maybe all encountered during an ICSI procedure that could be a bit more fragile, that did not respond well to being injected, for example. That is not something we see very often, but that is sometimes a case where ICSI could maybe be the unpreferred method of fertilization. Yeah. But that's something we see already in the fertilization stage, and not something that was further impacted on loss during development.
And out of interest, from this webinar that you did with your 2 experts, did they do 100% ICSI for like operational efficiency, or was it more to more of a medical?
Yeah, no, not medical. So it was even for non-male factor patients. So it was just 100% for all. And I think it was to eliminate the risk of a failed fertilization, mostly, which I think we see maybe, what is that, roughly at 3% of all cases, maybe 3 to 5% failed FERT in IVF. So it's not insignificant depending on the size of your clinic.
But arguably, you could say that 100% ICSI can increase your utilization, just because you might get more fertilized oocytes. You do, and then we're just playing with an economy of numbers then, right? So we're just increasing the number of potentially FERTs, but I think the numbers are quite low. So as you said, less than 5%.
Yeah. Renata, you have thoughts. Go on. Sorry, we do have a few more questions.
Just a small comment again. So because you already had that discussion about the ICSI, yes or not, so whatever. So I just added some notes again. So nowadays we have studies, and because when the ICSI started, of course, we had many studies about the follow-ups and follow-ups if there is some like effect of the ICSI on the health of the babies born after ICSI. And in these days, we have studies that there is no differences between IVF and ICSI. So that's ICSI, it's safe technique. That's the first thing. So just mention it. Then another thing is that there could be, like the center still can have another policy as well. For example, if there still could be something behind their decision to using ICSI to get more information, then, for example, if some clinics running the donor program, so if you need to match the donor and recipient, if you need to stimulate the donors, if you need to get enough eggs for the fertilization and measured eggs as well. So of course you have to be sure that you are not losing any eggs because of some biology during the conventional IVF. So that could be always behind that. If you want to use a time lapse, as David mentioned already, so you need to strip the eggs from the cumulus cells, and then you need to fertilize the eggs by ICSI as well if you want to get the first information about the quality of eggs, whatever. So there could be many things behind that, and still can imagine that again, as we again say that there is a policy how you want to treat the patients, and everything could be adjusted for the patient. So again, some patients may need IVF, some patients may need ICSI, even for getting the information. So still remember the patient when we had really bad quality eggs, so then they wouldn't succeed by conventional IVF just because of the quality of the eggs. Even the reaction of egg and sperms was able, but we needed to help the eggs as well. So there, so many things could be behind that. So
yeah. No, it was interesting. You mentioned in order to do time lapse immediately, you need to do ICSI. There are a lot of clinics that are starting to do short inseminations now with IVF, and then stripping and putting straight into your time lapse on day 0. So there's a lot of of changes going on.
Yeah, and again, there could be like the time for the insemination during the conventional IVF. So there again, some rescue ICSI, whatever. So as I said, so that's the whole pool of the things what we may use and what we may do.
Perfect. Great. Well, we've got a few more questions that have come in. So one is really quite interesting, and I don't know if either of you have worked with donor egg programs, but somebody, based on all this attrition rate that we're talking about, how do donor egg programs guarantee at least one blastocyst? Like, how does that work? How can they guarantee that? David, do you have any?
Yeah, so it goes kind of back to raw data. So it goes back to looking at the data, and it's difficult for a donor program to say it from the start. But over time, a donor program is able to calculate based on how many oocytes, mature oocytes, are allocated to a patient, how many of those will fertilize and how many will turn into blastocysts. And so in that way, because donors are going to have the highest possible prognosis as well, they're thoroughly tested, they often have proven fertility. And so we can say with a pretty decent amount of confidence, again, talking about that conversation of things don't always, there's no such thing as 100% in biology, right? I think that's the thing that we tell ourselves all the time in embryology, because we know that things can go really well or not so much. So, but looking at the raw data and looking at all of those factors of attrition from using donor oocytes, we're able to, with a pretty significant level of confidence, guarantee a blastocyst. And so I think it really kind of comes down to that. and obviously coming down to recruiting very good donors as well. So yeah.
And you definitely need a very strong vitrification protocol to be able to guarantee those oocyte survival. Exactly.
Skills paramount, and a lot of experience, I think, is a good factor there, because of course we've been talking a lot about freezing blastocysts. Blastocysts have over 100 cells, but an egg is one cell, and it's one very large cell, and it's full of water, and water will kill the oocyte when we freeze it. So it's very, very different to freezing blastocysts in a conventional way. But as we've already said, we can apply different strategies to different stages, from oocyte to blastocyst. So yeah, very true, Sandy.
Thank you. Renata, I've got a different question for you. So someone is asking, is there anything that can help the blastulation rate and possibly lower attrition, either before, during, or after stimulation and egg retrieval? So this person says they've had 74 eggs collected over multiple cycles, 74 eggs, 54 fertilized, and only 11 make it to biopsy for PGTA, and they're 38 years old. Sorry, that's a lot I've thrown at you, but if we look at the first part, do we think there's anything that can help that blastulation rate?
The my theory behind all the thing is that unfortunately it's very hard to change the egg quality, because they are already prepared for whole reproductive age of the women. So that's the problem. But definitely good lifestyle, of course, would help. So that's some abuses, so smoking, alcohol, whatever, and some antioxidants may help as well. So, but again, so wouldn't give you the big changes in the egg's quality. And another interesting thing is that always when we stimulate in each cycle, so we are getting, let's say, like a wave of the follicles, which will grow, and we will get some certain group of the eggs, and all of them in that group will have almost the same quality, because they are originated from one group. And there is a theory behind it called cohort theory, that all these eggs will have the same quality, even you will get less or more blastocysts. But if you are not if you have, let's say, I don't know, 15 embryos, then you will get 5 blastocysts at the end. And for the one cycle, you will have actually better quality blastocysts than from another ones. Even the same patient, the same stimulation, whatever. So, but still, because from 2 different cycles, 2 different, let's say, wave of the follicles, so there'll be different quality of the blastocysts at the end. And using all 5 from the first cycle, you would never get pregnancy. Doesn't matter, we wouldn't talk about the aneuploidy or aneuploidy, so that would be complicated. So, but using the another 5 cycles, 5 blastocysts from another cycles, you may succeed with all of them, let's say. This is really depend again on several factors which are not very well known, and what we can do with it. Not really too many things.
That's a good point. And you made a really great point at the beginning too, Renata. So there are some things that we can do, whether that's like dietary and lifestyle, that can help potentially protect the ovaries a bit in the environment where the eggs are maturing in. But there's a limit to how much that can actually help and change. Antioxidants can be great at, protecting from oxidative stress, for example, but that might not be the main cause of any quality concerns, for example. And so there are a lot of people that will try to make lots of changes to help, improve the outcome next time, and just know that you could be doing all of the right things, and just sometimes these things are beyond your own control, unfortunately. And this, the cohort theory is also, it's fascinating. And
just one edit note, small note, is that if you want to change something by taking some nutritions, whatever, so you need the time. So you need to take them at least 6 months. So, and that's what somebody doesn't really think about. So they just taking some supplements just in the cycle when they want to do the stimulation, and there is no effect then at the end. So
yeah, I think we often hear around 3 months, at least, in the UK from some of our physicians, that it's the time that it takes to recruit, follicles in these different waves through maturation that they go through in the ovaries. There is a bit of a range. So
I know that there for some nutritions could 3 months work. So, but generally, if you look at any nutrition study, so you will see that it's, let's say, the 6 months is something what is the average for most nutritions what you need to take in the consideration to improve something.
Yeah. All right. So we just had an additional comment to that previous question, was just that I think six of the ICSI embryos had made it to blastocyst and PGTA testing. However, all of the conventional IVF failed on day 3. Good quality egg. So yeah, again, that would be related to that specific cycle, the cohort that was in. It could be just generally how your eggs might fare better with ICSI as opposed to IVF. Any additional thoughts on that last one, David?
Yeah, it's incredibly difficult, unfortunately, to pin down. As you said, there's it could be a specific cycle where they decided to do ICSI. It could be a slightly different stimulation that they used. Could have been the first cycle. And then we've got age factors that come into it. So I suppose, it's incredibly difficult, I think, to really pin down how or why that impacted on that cycle. So yeah, I think kind of tricky on that sense. But I think when we're talking about like lifestyle factors, and we're talking about how things might affect fertility, and as you both said, it's very difficult really to have this impact. Fertility is really delicate, and we know that there's many things that can disrupt menstrual cycles, and it's kind of just clean living in terms of a general term. And I know that's probably unhelpful to use as a general term, but it's like, just don't add toxins, which is, alcohol, smoking, BMI is important. And, you can use antioxidants in moderation, because, there's always a scale there of going too far in any one thing, and because biology is always a balance. But yeah, just wanted to say that.
That's brilliant. Well, that was all of our questions and comments this evening. Big thank you to everyone who joined us for your brilliant questions. I hope we've answered them well. The recording of the session should be coming out via email tomorrow. You could also access it on the My IVF Answers website. Thank you to our experts. Thank you so much, David and Renata. It's been a great conversation this evening. Thank you for your time. I do believe we are going to be back next week already with our next one. But yeah, if you are on the mailing list, you should get emails around the next Ask Your Embryologist. But yeah, thanks again. Enjoy your evening. And we'll see you next time.
Thank you.
Thank you for the invitation. My pleasure. Bye.
Bye.